All right, everyone. Thank y'all so much. It is 12 noon. We are going to get started on time. I want to be respectful of everyone else's time and be respectful of our panelist, our guest panelist, Joe Mercer. Thank you for joining us. No Surprises Act webinar. First thing I want to make clear is that we really do want your questions. If you take a look at the GoToWebinar control panel on the right-hand side of your screen, you can ask questions throughout the entire webinar and we will get to them at the end. So please get started in asking your questions and we'll be happy to get to them. I'm going to start out with introducing Joseph Mercer from Marwood Group. I'm not going to take away all of the limelight from Joe. I want him to talk certainly, but we are just so excited to have him because he used to work at the Center for Medicare and Medicaid Services, CMS, who has stipulated all the regulations associated with the No Surprises Act. So having him here is just really a great pleasure, and I'm really looking forward to his insights. So Joe, please go ahead and introduce yourself and tell us about your background.
Sure. Thank you very much. Yeah, Joe Mercer. I have worked at the Marwood Group for the last 7 years. Marwood is, just for those of you who haven't heard of us, it's a healthcare advisory and consulting specializing. We do diligence work for private equity transactions as well as companies, healthcare companies buying other companies. We also do corporate work with a strategy practice, but also from a federal perspective. I work in the DC office. We're mainly based in New York, but I work in the DC office covering basically everything on the healthcare services and managed care side coming out of Congress and CMS. So this is something where we published a bunch of work on the on state surprise billing laws back in 2018. And so when Congress started talking about it in mid to late 2018, it's something we followed very, very closely throughout the process. And now I thought when they passed it, there'd be less to do. It turns out it's quite a bit more. As Dr. Kaplan said, I came over from the Centers for Medicare and Medicaid Services, where I worked to implement the Affordable Care Act from just a few months after the law passed, including helping to set up the ACA exchanges. So not always right in line with everything I cover from Marwood, but the insights from CMS certainly do help. So thank you very much for having me. Looking forward to it.
No, so excited to have your insights. Really appreciate you weighing in on some of the answering some of the questions that I'm sure we'll have. All right, so I am Jonathan Kaplan. I'm a board certified plastic surgeon in San Francisco and also the founder CEO of BuildMyHealth, a price transparency lead generation platform, and now a No Surprises Act compliant platform. And we'll be talking about some of the solutions that we can provide after going over the No Surprises Act. So I want everybody to be very patient. We have a very varied audience today. We have aesthetic cash pay providers or cash pay providers who aren't necessarily aesthetic. We have insurance-based providers. We have providers that do both. We have providers that are in multi-specialty groups that do both, radiology facilities, surgery centers, hospitals that are on the call today. So please be patient. If you're hearing about more about insurance than you want, stay tuned. I promise we'll get into the aesthetic or cash pay discussion. But really, this is going to be something for everyone to learn today. First off, let's just start with the basics. The No Surprises Act, it was passed in December of 2020 as part of a bigger COVID relief bill, and it is the law of the land as of this past January 1st. So if you're hoping this is something that maybe is going to be that's not been implemented yet or won't come into won't be official, it's already, that time has already passed. We are probably already non-compliant to some extent because this really did go into effect on January 1st. I will start out by mentioning that this does not apply to your patients who have Medicare, Medicaid, or any Veterans Affairs, TRICARE, any federal program, because those already have some surprise billing protections in them. But there is going to be some aspects of this law that applies to everyone. Those doctors that take care of patients with out-of-network care, out-of-network billing, uninsured care, self-pay, or cosmetic care, it applies to everyone, including this first part of the act that I want to highlight. You all have to, if you're a provider in the United States, you must post this public disclosure requirements. There's 2 of them. So just like you have the patient's bill of rights that maybe you have to post next to the front desk of your facility. And when I say the front desk, I'm talking about the place where people either schedule an appointment, schedule a procedure, pay a bill. Of that area, you must post 2 things publicly now. And that is on the left, you'll see the standard notice regarding patient protections against surprise billing. That is one thing you have to post. The other that you'll see on the right is the standard notice that you have a right to a good faith estimate. Both of these documents are available at that link I'm showing at the bottom of the screen. Take a screenshot, take a picture with your phone. I know the website name is kind of long, but I wanted them to be as descriptive as possible. But these are things that you have to post next to your front desk. And also you have to post them on your website, specifically on your homepage. You don't have to post the entire notice on the homepage of your website, but at the very least, a link on your website. You can check out my website, pacificheightsplasticsurgery.com. Check it out after the webinar, not now. And you'll see that there's a link on the homepage of our website to both of these notices that you have to post by your front desk as well. So this applies to everyone. And it's very basic. The No Surprises Act, the overall goal is to inform patients of their cost ahead of time, potentially avoiding surprise bills. And they focus this on two separate groups. And it's important to keep these two groups separate because some of the requirements are separate. First off, they want to provide pricing information ahead of time and avoid surprise bills for those patients that are using insurance. And they want to reduce surprise bills for those patients that are not using insurance, self-pay. So let's start with the first type, people that would be using their insurance and how they want to reduce surprise bills. Take, for example, you are on a bike, you get hit by a car, you fall on the ground, you feel like you've got a lot of pain in your arm, maybe it's broken. You have an ambulance that comes, picks you up, takes you to your hospital that you happen to be in network with your insurance plan. The ER doctor sees you, they send you for an x-ray, they take the x-ray, the radiologist reads the x-ray, sees that you do indeed have a broken arm. The ER doctor splints your arm and then tells you to go home and follow up with an orthopedic surgeon. Then weeks to months later, bills start to trickle in. You see the hospital bill that shows up and the ER bill that shows up. That most of it is being covered by your insurance because you're in network with those facilities. You still have to pay your deductible. So let's say it's a $1,500 deductible. You still have to pay towards that. Your out-of-pocket maximum is $8,000, for example. Your co-insurance is 40%. You still have to pay towards all of that for those in-network services. But then you notice the ambulance and the radiologist that read your x-ray, they're out of network. So you are on the hook for paying more out of pocket if you have out of network benefits, or you're on the hook for paying all of those services if you do not have out of network benefits. So if you do have out of network benefits, then maybe instead of $1,500 towards your copay, you have to pay $3,000 towards your copay. Your out-of-pocket maximum is $16,000 instead of $8,000, and maybe your co-insurance is 50% rather than 40%. So if you have out-of-network benefits, a lot of it is still covered, but you still have to pay more. And the No Surprises Act was meant to eliminate those surprise bills for situations when you go to you're in an emergency and you go to an in-network facility or an out-of-network facility, and they try to balance bill you or charge you more with surprise bills because you're out of network. So that's where this applies. However, so the No Surprises bill would cover the radiologist bill who's trying to bill out of network, but it won't cover the ambulance service. The ambulance service can still bill out of network. The No Surprises Act, when Congress wrote it, they excluded ground ambulance services from the No Surprises Act because they felt like in a lot of situations, the ambulance service is either owned by the county or the city, and so they didn't want to have to write rules that have to deal with or pierce the bureaucracy associated with the county or city. So they just excluded them. So the federal government writing laws excluded other governmental entities from the No Surprises Act. The thing that's particularly frustrating thing about this is that, the ambulance services say, well, we have a lot of expenses. We need to bill out of network so we can get a higher reimbursement so we can help cover those services. Well, that's the same reasoning that the doctors had, that they had a lot of expenses and they were billing out of network for specialized services they were providing so they could get higher reimbursement. Well, now with the No Surprises Act, in emergency situations, the doctor has no recourse. They can no longer bill out of network. We'll get to what they can bill in a second. But the ambulance service, because they're owned, in a lot of situations, owned by the county or the city, they still not only can bill for out-of-network services and get higher reimbursement, but they're also getting tax revenue from the city and the county. So very frustrating, a lot of hypocrisy there that they don't have to play by the same rules, but I digress. The other situation that the No Surprises Act was meant to minimize the potential for surprise bills is if you go to a hospital or a situation where it's not an emergency. Let's take an example like you're a woman giving birth, you go to the hospital that's in network, your OBGYN is in network, but the anesthesiologist that puts in your epidural is out of network. This is also now disallowed by the No Surprises Act. So in a non-emergency situation, if you're in a in-network facility, if there's an out-of-network provider, they cannot bill you for out-of-network services unless they get consent in certain situations. So there are exceptions in non-emergency situations. So to be clear, if you're out of network in an emergency situation, nobody can bill you out of network except the ground ambulance service. In a non-emergency situation, you can still bill out of network if you get consent ahead of time. So this will apply to the plastic surgeons listening who provide a type of breast reconstruction that is out of network. You can still bill out of network for that breast reconstruction in a non-emergency situation, of course, as long as you get consent. And the consent looks a little like this. This is what CMS, the Center for Medicare and Medicaid Services, this is the consent form, at least the top of it, where you have to use a consent form like this that has the exact same verbiage, where the patient signs away their rights, essentially is what it's saying. They're signing away their rights to only getting billed for in-network services, that they're going to get billed out of network. And it also says that they don't have to sign this form, but if they want your services as an out-of-network provider, they will have to sign this consent. So that's allowed, that you can still bill them out of network if they sign this consent. But also, and you'll see this bolded here, you also have to provide an estimate of what those out-of-network costs are going to be, and including not just the out-of-network costs like the negotiated rate or the out-of-network rate, but you also have to tell them what their responsibility is going to be as far as their out-of-network benefits, or if they don't have out-of-network benefits, you're going to have to provide them with an estimate for that. Now, there are exceptions to the exceptions. So the exception to the No Surprises Act in a non-emergency situation is the doctor can get the patient to sign a consent. But there are doctors that are not allowed to get consent and bill out of network, even if the patient chooses to. So those exceptions are ancillary services, ER physicians, anesthesiologists, neonatologists, radiologists, the lab, the pathologist, assistant surgeons, intensivists, hospitals. They cannot they cannot give you a consent form saying that they're still allowed to bill you for out-of-network services. I want Joe to chime in on this, of course, but also I want to ask, what if there's not another in-network provider that provides that service? So take again the example of a plastic surgeon that does breast reconstruction, they're out of network. What if there's not another in-network provider that performs that exact type of breast reconstruction? Joe, I'll let you take it away from there.
Yeah, I mean, in that case, if there's no in-network option, then you really can't do notice and consent. Now, I mean, again, I think the initial focus of that was really more about these ancillary services, but in general, I think the lack of, if there is no available in-network provider, it is going to be difficult to use the notice and consent to get away from it. It's going to be, you know, I don't think that for most of the Surprise Billing Act was, or the No Surprise Act was put together with the idea of aesthetics in mind. But in this case, I think that you would be swept up a little bit if there literally is only an out-of-network option in a given hospital for any given procedure. It's going to be difficult to use that notice and consent.
All right, that's probably not the answer a lot of reconstructive plastic surgeons who are out of network wanted to hear, but hopefully there are some in-network providers that they would still be able to get consent if that's the case. So I was talking about this before, that you can't bill out of network if it's an emergency situation or you don't get consent. So what do you get paid? And that has been restricted to the payment is now the median in-network rate. When Congress wrote this, they said that, you know, if you're going to have to be shifted to an in-network rate, you can take a lot of things into account. You can take, you know, what you've been paid in the past. The problem is that when CMS implemented the regulations, they tied that in-network payment when people are trying to bill for out-of-network services and don't get consent and it's an emergency situation. CMS said, well, we're going to start with tying that payment to the median in-network rate. So a lot of people were unhappy that they've basically put pressure on the scales in favor of the insurance companies who would determine that median in-network rate, which is why there's a lot of lawsuits by the AMA now, Texas Medical Association, which I believe they're starting oral arguments on February 4th. The anesthesiologists who aren't able to bill out of network pretty much for anything now, they're part of another lawsuit. So there is, if you're unhappy with that in-network or that median in-network rate, there is an independent dispute process that I'm going to have Joe talk about and also some of the violations associated with the NSA.
Sure. I mean, just the easy thing to start with is that if you are sending surprise bills to patients, that you're going to get a $10,000 penalty for, for every violation, which is not great, not super ideal, but the easy answer is to just don't send the bill in those situations, right? And obviously, I say that sitting here in DC, not having to go through the operational hurdles there, but we can move past that. That's just a very, very straightforward piece. The internal dispute resolution process, the arbitration process, is basically after you have an out-of-network bill, you have 30 days to negotiate with the payer. And in some situations and in some specialties, that especially ones that aren't as big a focus for the payer, or some places where the median in network is a little bit of a tricky scenario, or just they don't feel as confident in it, I think there will be opportunities to not have to go to the IDR process in that step. But if you can't get to a mutually amenable rate in that 30 days, one party, presumably in most cases the provider, can go to arbitration. In arbitration, this IDR process, which can be can be done over one particular bill, or it could be a batch or a bundle of a whole bunch of bills. And so, like, you highlight the fees for a single determination, which go to the loser. You can bring in, a whole 90 days essentially worth of different services and do them all at once to try and reduce that cost. Because otherwise it would be, for many, many specialties, it would be completely unusable. But in the IDR process, both the provider and the payer submit a bid. And this is like baseball style arbitration. So if somebody says 100, the other one says 10,000, one of those two has to be picked. There's no cutting the baby in half, no middle position. And as Dr. Kaplan was saying, the big focus, the positive for payers, is that the HHS CMS has said that the presumption is that the qualifying payment amount is the correct rate for an out-of-network service in that market, and that QPA is going to be based on the payer, the region, the service, and the service, and it's going to be all tied to January 31st, 2019. So that's the starting point. So if it's not great there and you don't feel good about that rate, it's going to be difficult to go ahead and get around that. But there's some things you can highlight. You can highlight your relative quality or education or outcomes as that's one thing you can use. Then the next thing is you can talk about the acuity of the patient. If there were a lot of complicating factors that made this particularly difficult. The next thing you can look at is market share. If you're in a market with a large payer that has almost all the power, it's possible, if not even probable, that the QPA is unnaturally low. And so you could say, look, this is why they've been able to negotiate these rates. This is why we were out of network in the first place. They were being unreasonable to start with. They had all the power. And then the last thing I want to talk about is prior contracted rates or good faith attempts to contract. If you have had, let's say you've been in network with United for years doing breast reconstructive surgery, you've been in network for years, and they say, look, this is an opportunity for us to cut your rates. They kick you out because they have a couple rates that are lower. You can go to the arbitrator and say, look, at a arm's length transaction, market-based rate, our market rate was $5,000. I don't know what a breast reconstruction costs, so I'm just going to use the number, $5,000. And yet that may be an opportunity to say, let's go above the median. So those are a couple of the mitigating factors. Obviously, as mentioned before, this does weight things to the payers to a certain extent. But if you have a specialty that does tend to have higher median in network rates in that region, that's going to be a level of protection, and then all the other factors I mentioned.
I mean, that's good to know that the doctors or the providers have that opportunity to go back and fight. But I am afraid that it's going to be such an onerous process that they're going to do it once and then they're just going to throw up their hands and give up and either go out of network or just stop servicing that hospital's ER, or if they have that option, which is a shame. It's a shame that they're driven to that, not a shame that they're choosing to do that. Thanks a lot. I appreciate the insight, that feedback. So now I want to shift from talking about the surprise bills associated with insurance versus the surprise bills when people are not using insurance, whether they're paying cash or self-pay. And that's when the good faith estimate comes in. So we're totally shifting gears here from the insurance to the cash pay services. And a good faith estimate now needs to be provided to uninsured patients, and it also applies to people that that have insurance or choosing not to use insurance or self-pay, and that may mean cosmetic as well. When I say that people are not using their insurance, why would somebody not use their insurance? Well, quick example is you need an MRI, you've got a $1,500 copay, a deductible. You haven't put anything towards that deductible. You go to an outpatient radiology facility. They say, well, the MRI, the negotiated rate of the MRI, if you go through insurance, is $1,500. So you can submit it to your insurance, and they won't pay anything because you haven't met your deductible, and you're going to pay the whole $1,500. Or you can just pay us cash up front right now for $350 and get your MRI that way. And so that is something that people are doing more of. They're shopping around. They're seeing that the cash rate is better than the negotiated rate. So that is why people would have insurance but not use it. And in that situation, they will need to have a good faith estimate. Now, even though I don't believe that Congress or CMS has aesthetics on their radar and that they intended for this to apply to aesthetics, according to the letter of the law, because they say self-pay, this does apply to cosmetics. And I even feel like this quote from the good faith estimate of the rules that I've highlighted here, that I've bolded, it says that you provide the good faith estimate to people that are not enrolled in coverage, that they're uninsured, or people that are enrolled but not seeking to claim their service with their insurance company. Well, aesthetics, the patient's paying out of pocket not because they're choosing not to submit it to insurance. It's because insurance doesn't cover cosmetics. It's not an option. So that's why I feel like their intent was not to cover cosmetics or aesthetics, but because they use self-pay, it's been swept up in there, to use your term, Joe. Would you agree with that?
Yeah, I mean, yeah, it's more of a, we're just going to try and do everything we possibly can. Basically, the idea here is that, and you'll talk about this, I know, on the coming slides, but I mean, the good faith estimate is really about trying to drive towards an advanced explanation of benefits. But then, if you see this has happened a few times in the last couple of years. Anytime there's a big change in insurance coverage, regulations or law, there's a pushback to say, like, well, we don't have universal coverage in the United States. What are you going to do about people who aren't insured? And so this is the, sort of the reaction to that, and saying, well, if you're not insured, we want to make sure that we're going to go ahead and cover you and have you at least understand what the prices are, force a little bit more transparency on the front end. And so, yeah, the idea here is at least a little bit in part, I think that behavioral health is much more an area where this is, some of the rehab centers that are self-pay only, things like that, I think this is much more where it's intended. But obviously, especially in this initial cut, aesthetics is just, they count. And so they're not going to, at least not in the short term, they're not going to carve anyone out.
And I know that the American Society of Plastic Surgeons, they look at this and they feel like self-pay does include cosmetics. And so they're asking CMS for clarification. But I mean, who knows when that clarification will come, or if it will be the answer that some people want to hear. Unfortunately, I think that no matter what, all of the Trump price transparency rules, the No Surprises Act, it's all driving towards more price transparency, irregardless of provider or even the procedure that's being performed. It's just globally more price transparency is what they're going for. But as far as the good faith estimate, continuing on, it's you have to provide an estimate within 1 business day if the procedure is scheduled within 3 days. You have to provide an estimate within 3 days if it's scheduled out at least 10 days or more. Either way, you can't provide the estimate more than 3 days after it's been requested. And there is a dispute resolution on the part of the patient if the ultimate bill is more than $400 or more than the good faith estimate. And just to kind of keep it all separate, with the No Surprises Act in regards to insurance-based services, remember there's a dispute process, but that's between the doctor feeling like they're not getting paid enough from the insurance company. For the good faith estimate, for people that are not using insurance, this dispute resolution process is specifically between the patient and the provider. So keep those, recognize that there is a difference in those dispute resolution processes. Now, continuing on that road, as far as the differences between the insurance-based estimates versus the cash pay or good faith-based estimates, these are 2 different types of estimates. They have different elements, different requirements. So starting on the left, there's the out-of-network estimates that you have to get consent and let the person know how much their costs are going to be. With this estimate, you have to include the patient's name, the CPT code, cost for the provider, the consent, as I mentioned, but you're also supposed to list other in-network providers. What we're currently doing is not listing individual providers by name. We're letting them know that they should check with their insurance company to see who is in network, because we don't know who's the in-network providers, but the insurance company will know. And something that's not being implemented yet, but it is part of the law, is that the out-of-network estimate that you're providing as the provider, you're only showing them your fee. But what's coming down the road with the advanced EOB, explanation of benefits, is that you're going to send your fee to the insurance company, who's then going to turn around and then send an explanation of benefits to the consumer before the procedure, including your fee, but also letting the consumer know what the hospital fee will be, the anesthesia fee, other ancillary fees associated with that procedure. So whereas the explanation of benefits was done after the fact, like letting the patient know, okay, you did this and this is what's being paid and this is what you're going to have to pay. Now they're talking about doing the advanced EOB, where the consumer will have a better idea of the cost ahead of time. But the technological infrastructure for that isn't complete, and so that's why it's not being required as of yet. Joe, do you have any idea what the timeline on that is?
No, not really. I mean, I think that realistically, you could see regs in mid. You could see a proposed rule. I suspect they won't use an interim final rule process for this because they have more time. A proposed rule in I want to say mid 2022. It's possible. Okay. And with the idea that, like, I know a lot of the asks from the hospitals and others have been for the good faith estimate and advanced EOB regulations to be, or implementation and enforcement to be pushed off until 2023. You could see a world where it could slip further into mid 2023 very easily, those requirements, just because there's a lot there. And frankly, as we talk to, I know that there's a lot of providers that are saying, like, this is a major lift operationally for a lot of folks. And so they're worried that this is going to be a really significant thing that I don't think that, to give you a little background, I don't want to take a lot of time with this, but like for the longest time, the No Surprises Act precursors that were discussed in Congress included a ability for a patient to request a good faith estimate in advanced EOB. It was a request and they had to get back to you within 48 hours. In the final rule, for whatever reason, it became much more sweeping. And I do think that it's going to take the Biden administration some time to wrangle with what this means and how much they can really ask of providers. So if things are going to get slow and be slowed down, I suspect that's only going to be good news, A, because the enforcement deadline's going to be pushed off, but B, because it means they're actually listening and saying, wow, this is a lot to ask of providers and with only limited value in many cases to the patient. So we'll see. I think a proposed rule in June, July, with the final rule in September, October for 2023 wouldn't be unreasonable, but it could very easily slip past that.
All right, that's actually really helpful background information regarding the previous bills. So again, that is for the insurance-based out-of-network estimates as far as the advanced EOB. Now, on the other side of the page, you see the good faith estimates. This is again for the cash pay services. You have to include the patient's name, the provider's tax ID number, not the patient's tax ID number, your NPI number, CPT codes, the diagnosis codes, and you're thinking, well, a Brazilian butt lift doesn't have a CPT code. You just basically leave that blank, but there are diagnosis codes specific to cosmetics, which I'll get into. The cost of the provider, you have to have the consent, or at least make them aware of their good faith estimate. And then starting in 2023, there's the concept of the convening provider who will have to collect all the estimates. In a sense, it's like the advanced EOB for the insurance side, the convening providers for the cash pay side, that you're going to have to include not just your estimate as the provider, but the OR and anesthesia as far as those providers. And so I want to delve in a little bit more into the convening provider idea. And this is a conversation I was having online with the American Society of Plastic Surgeons on their message board with Dr. Plastic. He's a plastic surgeon in Chicago. And he was saying that the hospital is contacting him, asking him for his whole fee schedule because they're claiming they're the convening provider. They want to put the OR rates, the anesthesia rates, and his fees together as part of this good faith estimate. And this could be for cash paid, not necessarily aesthetic services. Maybe it's a breast reduction that normally could be covered by insurance, but just isn't right now in this particular situation. So I don't want to focus on plastic surgery only, but I do want to point out just cash pay services with this good faith estimate. And what I was telling him is that he should be the good faith estimate. He should be the convening provider. He shouldn't just outsource it to the hospital, because I used to work for a hospital. Good people, it's a good place. It's a good hospital. It was a good place for sick people to go. But you can't assume that the person who's putting together this good faith estimate as the convening provider is the smartest person that they have at that organization. There's chances that they're going to provide a good faith estimate to the consumer that is incorrect, and puts down a price that is incorrect for your services. So even though the patient may pay you up front $1,000 for whatever service, And then they get the good faith estimate from the hospital that shows your service is $800 because they used the wrong estimate from the wrong fee schedule. It's going to cause confusion. The patient's going to say, well, I paid you $1,000. This says it's going to be $800. So I would argue that you need to be the convening provider, and you should provide not only your professional fee, since you'll know you'll get that right, but you can get the OR and the anesthesia fee schedules when it comes to cash pay services, because some of you already have that. You know that the hospital or the surgery center has a fee schedule specific for cash pay services, not necessarily aesthetic, but for cash pay services where you know the OR and the anesthesia fees based on time. So if you can get that, which maybe some of you already have those spreadsheets, you can make that as part of your good faith estimate as the convening provider. Now, something I want Joe to weigh in on here is that if you give that good faith estimate, you perform that procedure, you've been paid up front, you don't send a surprise bill, there's nothing for you to send. But let's say it took a little longer than the OR, and the hospital or the anesthesiologist sends an additional bill after the fact, and it's more than $400, and that is grounds for launching a dispute with the patient and the provider. I want to know, me as the convening provider, am I liable for all of the estimates, or is it just the provider that sent that bill?
Yeah, I mean, the convening provider, it's a great question. The convening provider is going to be responsible for gathering and sending the estimates, but at that point, that your responsibility sort of ends. Or obviously there are some pieces in the law where you can talk about if there's an ongoing procedure, you can put one good faith estimate for a year-long set of procedures. If that was going to happen, if you had follow-ups or things like that, and therefore over the course of the process, if things change, you'd be responsible for updating that good faith estimate. However, when it comes to other providers billing the patient, the convening provider is not going to be in the middle of that, right? It's going to be very focused on who is sending the bill, and they're going to be the issue, because the convening provider, all you're doing is taking other people's estimates and bringing them together and then giving them to the patient. If things go awry in that case, the responsible provider will be the one that provided the services and then sent the bill. It would not be the convening provider.
And I know somebody else will ask this question: what if the case does take longer? There's nothing wrong with you providing a good faith estimate that overestimates the OR and anesthesia time, and you only collect what you think will be necessary up front. And then if it does take longer and there are additional bills, that would be covered under the good faith estimate if you overestimated those time-based prices. Would that be accurate?
Yes, that's right. I mean, there's like, and frankly, even if things go over and they cost more money, it's going to be an easy dispute process because there's a specific reason why that happened, not just that your estimate is wrong. So no, I totally agree.
It wasn't really a surprise in that case, exactly. So again, the negotiated rates, as far as the convening provider, is specific to the good faith estimates, the cash pay services. But this, I just want to reiterate that advanced DOB that's specific to the insurance-based services, in that sense, I guess the insurance company will be acting as the convening provider, even though that term is not applied to them. I'm just trying to put it all in perspective. But keep in mind also that even though that might be strategic, technically a heavy lift for the insurance company to put all those prices together, keep in mind that as of January 1st, 2022, this past January 1st, the insurance companies were required to put all their negotiated rates, your negotiated rates, the hospital's negotiated rates, on their websites. They're not compliant yet because enforcement's not starting. It was pushed back to July of 2022. But you may not realize that, and you may feel like, well, I don't want everybody to know my rates. But keep in mind that your negotiated rates will be public on insurance companies' websites, theoretically by July 2022, if the Biden administration doesn't push back enforcement further. So keep that in mind as just another thing to remember. So I know this is all overwhelming. We're telling you that you have to provide all these estimates and you have to provide these consents and you have to do it in a timely fashion. And as I mentioned, I developed a price transparency platform several years ago that just happens to satisfy all these requirements of the No Surprises Act. So it'd be remiss of me to tell you about all these problems and potential heartache your practice might have without giving you some solutions as far as how to reduce chaos in the office when the patient asks for an estimate, or how to calculate the out-of-network responsibility if you are going to be billing as an out-of-network provider, and then how to include as many providers' costs as possible for you to be that convening provider, so you can kind of hold the cards and own your destiny rather than outsourcing it to the hospital. But we also need to talk about automating these processes. I know a lot of you out there, including my practice, We used to put all of our quotes and estimates on an Excel spreadsheet for each patient. It was like a manual process, or some of you are putting it on Word documents. We need something that's reproducible and also accessible for the future if the patient asks about their quote or their good faith estimate, or there needs to be adjustments made. So in the process of talking about solutions, I want to take a page from the credit card company's playbook. Back in the past, we had to, whether it was a convenience store, drugstore, doctor's office, we would hand the credit card to the person working at that location. And because they were, running the credit card was so complex, they had to be specially in-serviced on it, we would hand them the credit card. But now the credit card companies have shifted that entire process to the consumer. We put in the credit card ourselves, or we use our phone with Samsung Pay or Apple Pay. And so I want to use this as an example of what we need to do in our practices. We need to offload some of this responsibility on our own staff who are coming up with these good faith estimates, or who are doing the out-of-network real-time eligibility. For those of you who take insurance, you know what I'm talking about. We need to offload some of that responsibility and shift that to the consumer. And I'm going to talk about two ways to shift that to the consumer. One is a price estimator that sits on your website. One is a chat bot that sits on your website. Even though I'm going to use them for different examples, I want to be clear that both the price estimator and the chatbot both can provide insurance-based estimates, and it can provide cash-based estimates, which may include aesthetics. So starting with looking at my website, you would have a Get a Quote Now button on your website that would bring the consumer to a price estimator on your existing website, where they can check out the cash pay or the insurance rates for a particular procedure they're interested in. So you would list all of your negotiated rates, or all the insurance companies you have negotiated rates with. The consumer could choose United PPO. They can choose breast, going with that breast reconstruction example I used earlier. The consumer can choose the DIP flat breast reconstruction, which they've read about online. And then we would ask them what their deductible is, their out-of-pocket maximum, their percent copay if they have out-of-network benefits or in-network benefits. They might not know that information. All they have is their insurance card in their pocket. So they put in their member ID, their name, their date of birth. We capture their name and email address so we can at least get a lead out of this. We can get the patient's contact information so we can follow up with them. And then on the screen, they're showed what the negotiated rate is, but they're also showed the real-time eligibility of what they've put towards their deductible, their out-of-pocket maximum, their co-insurance. So they see what they owe out of pocket and what their insurance will cover. Now, the reason this is really helpful, aside from seeing this on the screen, and they get an email that's sent to both them and to the office staff, they see a breakdown of all the cost. The office staff sees their email address and their phone number. They see the pricing. They see what their responsibility is. But the reason this is so important, aside from them seeing the price, is that now they've found out that information before they go in for the consultation for their insurance-based service. Because most people, they go to their appointment thinking, I've got insurance, it's going to cover everything. And then when they have the consultation, they find out that at that point, I mean, think about it. People get upset when they find out they have a $40 copay. They think, I have insurance, why do I have a copay? Well, they're going to be really upset if they go and talk to the business manager and find out that they have to pay $8,300, as this example shows, out of pocket to get this procedure that supposedly is covered by insurance, which of course, insurance is covering a large portion of it. So this gives the patient a more realistic understanding of what their responsibility is before they come in. So very important to shift that information to the front end rather than at the end of the consultation. And so then by the time the patient comes in for the consultation, that estimate that they submitted through your website, it's plopped into the provider portal that our platform has for doctors and for other providers, is that your office staff logs into the provider portal and they can use this status quote feature that we have, where they can see all the estimates that have come in. And so they can see that estimate about the DIEP flat breast reconstruction, which takes tissue from the abdomen to reconstruct the breast. And so the office staff can look at that estimate. They can make sure the insurance rate is up to date. They have the patient's contact information. They can add in their address if necessary, because that's what CMS requires for these estimates. And they can add the diagnosis code. And then after they see the doctor, they may find out, well, they don't have enough tissue from the abdomen. They need tissue from their butt. So you can exchange out these procedures. You can take, as you can see at the bottom, you can take from your database of procedures that are already in our database and your prices that are specific to you. And so you can exchange out those procedures. So instead of the tissue from the abdomen, they take the tissue from the butt to reconstruct the breast. They can repass that through the insurance or the real-time eligibility, resubmit that. And then you can send the patient an email with a breakdown, and you can see all of their specific out-of-network benefits, or it would say if they didn't have out-of-network benefits, and it shows the patient's responsibility for that different procedure. And then you can, again, send the patient an email of that quote, or you can create a PDF or print out the quote. And then this is a CMS approved example of what the quote's going to look like. It's going to have the patient's name, diagnosis code, your MPI number, the procedure, the negotiated rate, and then a breakdown of all the prices specific to that patient's insurance. And here's that surprise billing protection form that I showed you earlier that has all of the information that's necessary. So now you don't have to pull up additional pieces of paper, additional forms out of your drawer to give to the patient. It's all included in that quote that you're probably going to have to give the patient anyway, and they sign it at the bottom, and you're done. And that's how it works with the insurance out-of-network estimates that and the consent all combined into one. Now, if you're doing cash pay or aesthetic, then let's use the example of doing that on the chatbot. Again, on the chatbot, you can also do insurance. So instead of seeing different categories of aesthetic procedures, you would have seen insurance-based procedures if you're using the chatbot. But let's say they're doing aesthetics, they choose the breast category, they choose breast augmentation with silicone implants, and then the consumer, again, is going to put in their contact information, letting the patient know, that we'll send you an estimate immediately after you submit this request through the chatbot, and the patient gets an email, the office staff gets the email with the patient's name, the procedure they're interested in, a breakdown of all the pricing, and you can see the patient's email address and phone number to follow up with them. And again, this drops into that status quote system on the platform, so the office staff can go through, find that estimate, and they can update it if necessary. And one of the things I want to focus on here is the different types of estimates. So if somebody just calls in asking about pricing, they didn't do it on the website, you can use status quote to give that patient an estimate over the phone. You can actually email them that estimate. But if it's just a estimate of somebody calling over the phone, it doesn't need to be compliant with CMS. You don't need their address. So this is just an easy way to pull procedures out of your database and email them that estimate. But if they do come in for a consultation, then you have to give them that official good faith estimate that has their address, that has the diagnosis code specific for cosmetic procedures, and then you can adjust that estimate as needed, but send them an email with the updated estimate, and then create a PDF or print out a quote that again has all of the information that is needed for the good faith estimate for cash-based services. It's got your logo, their name, the diagnosis code, and that procedure, and then that form at the end that apprises them of their right to have a good faith estimate, which is required by CMS, and explains to them the independent dispute resolution process, the dispute resolution process for a good faith estimate, and then they assign it. So things that you would normally already do. So the thing that I'm trying to convey, and that's why I keep repeating it, is that these are things that you are already doing in your office. You just may be doing it in a less efficient way, in a more manual way. So right now, people are calling the office asking about insurance rates or cosmetic cash rates. And so now you're shifting that to the front end to allow them to check that on your website. Now, you don't have to have a price estimator on your website, but that is what consumers are going to start to expect, and it is going to offload a lot of that effort off your back office staff if they have that. But either way, they submit that quote through your website, then they hopefully come in for a consultation, the doctor sees them, and then you take up that estimate that they submitted online, or you create a new estimate if they hadn't done that already within the status quote system, and then you can edit that and you can adjust that as needed once the doctor's seen them, and maybe it's the exact same procedure that they did request. And then you can print out or create those PDFs or print out that quote specific to the out-of-network estimate with the consent form or the good faith estimate for a cash-based service. So all these things are already being done in your office, but we're just making it more efficient and using the platform to do it all for you. Now, something I want to go back to with the convening provider for aesthetic or cash pay services is that sometimes that estimate is just a bundled fee and it's just everything's all included. And so you can set up your pricing that way when when the patient is getting estimates, they can just get that bundled fee. But sometimes you go to multiple places where the time is, the fee, the OR and anesthesia fee is based on time. So you can enter in that fee schedule into this system. You may already have the spreadsheets for it, but now you're just digitizing it. And maybe you go to multiple locations. And so you can put in different fee schedules for different locations as far as the OR and the anesthesia fees. And then all of that is then incorporated into the cost of the procedure. And I'll just show you that where that kind of comes into play is that you have the database of all your procedures in the provider portal of our platform, and you have all those procedures, all those prices. And let's take, for example, body lift. And let's say you do the body lift as a procedure at multiple locations. Again, this is cash pay services, that you've got the description there that the consumer sees in the price estimator. And then you've got the MD fee, you've got the other ancillary fees, and you'll see the total price at the bottom is $41,000, but that is for that location. What if you switch to a different location? Well, because you have those fee schedules, that's all taken into account, and you switch that to the other location, and that price adjusts downwards about $3,000. Even though the MD fee is the same, just the OR and anesthesia fees have changed. What you'll see on the right there are some averages and how your prices compare to other doctors, and we'll get more into that in a second. But the idea is that you can account for all of these different locations when you're creating that convening provider good faith estimate. And if you are at multiple locations, it's all right. You can keep track of all that instead of having to use those spreadsheets and doing it manually, which you'll maybe make a mistake. This is a way for you to keep that all track of all that. And then there's other facilities that bill based on the procedure, not the time. And so you can also keep track of that as far as the MD fee, the OR fee, and the anesthesia fee. This is an example if they do a procedure not based on time, but it's a flat fee for that particular procedure. So if you're the convening provider, you can keep track of all of that. The thing that you might have seen before as far as the averages, well, because we have so many doctors and providers and facilities using our platform, we have a lot of pricing information. So if you are a radiology facility watching this today, you can see how your negotiated rates compared to everybody else for a CT of the head. You can see how your cash rates and your negotiated rates compared to other providers on our platform. If you are a hospital watching this, you can see how your right left heart cath compares, and you can see that this facility is getting $25,000, almost $25,000 more than the US average negotiated rate. So this just gives you an idea of where you fit within the competitive landscape as far as whether your negotiated rates are as good as they can be. And then this, of course, works for cosmetics or aesthetics, breast augmentation with silicone implants. I think this is actually my procedure. I charge $74.50 for a breast aug, and I can see that I'm below average for the West, state of California, 50-mile radius and zip code. And it also works for non-surgical services for lip augmentation with filler. This particular doctor is below average in their area. But for skin tightening and not a minimally invasive skin tightening procedure, they can see that they're above average compared to the US and the region, state, and down to the zip code. So very useful information. I know people aren't thrilled about price transparency, but you can use it to your benefit to generate leads, to comply with the No Surprises Act, and to also see where you fit within that competitive landscape, as I said before. So everything we've talked about today, all of the resources you can find at all of these websites. Take a picture with your phone, take a screenshot, but this includes all the different posting materials that I talked about originally at the beginning of the presentation. So in conclusion, and this is when we'll be happy to take your questions, we have a lot of questions, is that this is finally legislation that benefits the office. Think about HIPAA. HIPAA is great for patient privacy, nothing wrong with that, of course, but it didn't make your practice run any smoother. There was more paperwork. It didn't benefit your practice really in any way. You had to reach out to get additional information from another provider. So it wasn't that easy. Whereas this legislation, it actually is the impetus to allow you to make your practice that much more efficient by improving the workflow, by improving workflow, shifting more responsibility from your back office staff to the consumer on the front end when they're checking pricing, reduces the workload and the burnout of the back office staff because they're not having to answer questions about cosmetic or cash pay prices or whether the person has out-of-network benefits. They can find that out for themselves on the front end. And it's basically taking your existing tasks that you're already doing and making them more efficient. So we're not really adding anything. It's an opportunity to digitize your practice when it comes to the quote making process and the insurance process. So thank you so much. You can follow us on any of these social media platforms, and you can also email us with any questions. But now I'm going to bring Joe back on, and we're going to start to go through all of these questions. We'll get to as many of them as possible. So this question is, had a call from a patient who we saw and subsequently sent a specimen to a pathology lab. The patient received a bill from the lab who is non-participating with her insurance. How should this be handled, prevented? So a lab is actually one of the entities that's an ancillary service that is not allowed to bill out of network. Is that correct, Joe?
Yeah, that's right. I mean, yeah, they wouldn't be, the path lab would not be able to provide notice and consent. So if they're sending out-of-network bill, then they should always be swept up in the No Surprises Act. Now, that means, again, when the patient gets that bill, they need to go ahead and pay their in-network cost sharing, and then they, the path lab is going to have to deal with the insurance company if that's what's going on. If not, then we have a little bit of a different situation. But either way, it should be the pathology folks.
Yeah, and also I guess it's important to know, since we're so close to the implementation of the No Surprises Act, I guess if this happened in December, it wouldn't technically be covered. Or if the procedure was in December and they got the bill in January, would it be covered by the No Surprises Act?
Yeah.
All right, the next question is, how does a plastic surgeon approach the situation where there is a patient in the ER with a simple linear laceration that the ER is willing and able to repair, but the patient requests a plastic surgeon for the repair, understands they're willing to pay extra for out-of-network plastic surgeon, this out-of-network legislation. So the question is, if they're in the ER, but it's a laceration, and I think the doctor's basically asking, if it's not technically an emergency that the plastic surgeon sews it up, are they able to get consent and charge the out-of-network rates, even though the patient is physically in an emergency room?
Yeah, so I believe so the specific consent issue there, I mean, you should be able to get the patient to give consent in that situation. The big question with anything in the emergency room is whether or not they're stabilized and whether they can give consent to go outside of that. That's not so much going to be, I mean, obviously it will, some of the risk will accrue to the plastic surgeon there, but the emergency department, it has a lot of requirements for what they can do and what the hospital is allowed to do in order to let that person make that type of decision. So if they're stabilized, then they can go ahead and the ER is going to wash their hands of it. Now, if anything has happened while the patient's not stabilized, then the emergency room, everything is still going to be considered under the No Surprises Act. So the stability is going to be really important. There's a lot of really specific regs on that I probably can't talk about at length now, but would be happy to do so at a later date.
I know what the regulations you're referring to, the fact that like if people go to post-stabilization services like a rehab, that if they give consent to do like out of network for that they have to be able to go in a non-medical transport. Like if you're transported in an ambulance, then that's not considered stable enough. So that's interesting. But then in regards to this specific question, I would think that if the ER doctor is reaching out to you as the plastic surgeon to say, hey, this person wants the plastic surgeon to sew up their face, they're not comfortable with us doing it, inherently, to some extent, the ER doctor may be recognizing that the patient is stable, that they can have the time to have a plastic surgeon come in. So in a way, the ER doctor is kind of saying they're stable, and that would seem to me give the permission to the plastic surgeon to get notice and consent and bill out of network. Next is how are good faith estimates handled for hospital-based providers such as pathologists? I'm happy for you to answer that. I think that they're asking because they want your answer, not necessarily my answer.
Well, I mean, in most cases, the hospital is going to be the convening provider there. I mean, it depends. A lot of it depends on how it's going to work, right? If you're going to go to the example you provided before, if you are an aesthetics doctor working in a hospital and you've set yourself up as something of a convening provider, you've worked that out with the hospital that in your line of work, you can be the convening provider. You can go ahead and do that, and then you can bring in, from the pathology estimate there. If the hospital is going to be the convening provider for everything that happens within its four walls or in its outpatient departments as necessary, then they're going to be responsible. They're going to come and ask you for an estimate and come and ask the pathologist. So it's really going to depend case by case. I think, I'm not always as good at operational stuff as you guys are, but I believe that's going to be the sort of decisions that are going to have to be made at the hospital level in those cases.
And the way I would answer this, and the way we handle this, is that when we do a procedure like a breast reduction and there's pathology, we send breast tissue and it's a cash pay service. What we do is we include the cost. We have a set flat rate with the pathologist when they review that breast tissue, and it's like $350. We include that in our estimate, but we don't charge for that. So we let the patient know that it's $350. You're going to get a separate bill, pay cash for that. So that is how we handle the good faith estimate in regards to pathology. We don't collect for it, but we do let them know about it because we are the convening provider. So next question is, what can you do if you don't accept insurance for a procedure that may be covered, such as a removal of a cosmetic implant, has a slight contracture that we don't meet medical necessity, but Blue Cross Blue Shield is not no authorization required. In these cases, we have told patients we will not submit to insurance. It is cash only. Patients generally agree, but once in a while they fight and want insurance billed. So this is something that I don't know that this necessarily falls within the No Surprises Act. This is something that, a mole could be paid in cash. You could submit it to the insurance. As far as taking out a breast implant, if you choose to do it via cash, the patient may want to bill insurance, but I think that's their choice if they want to submit the paperwork. You still have the choice of if somebody's coming to your office and you're providing a procedure for them, I think the doctor still has the opportunity to say whether they want to do this as a cash-based procedure or insurance-based. Would you agree with that this might not necessarily come under the purview of the No Surprises Act?
I agree. That gating question is going to be much more about what the provider wants to do. After you get past it, there will be, regulatory issues here and there, but that gating question is still very much up to the provider.
Okay. And then the next question is, when providing a good faith estimate, does the patient have to sign the estimate as it becomes part of the patient's file? Yes. I mean, as I was demonstrating, and this might have come up before I even demonstrated it, but as our quotes show, the good faith estimate, all that information as far as their rights, as far as disputing a bill that's over $400, that's all included in their estimate. They sign that. That is part of their medical record. This process is very time consuming and adds to an already exorbitant overhead. Well, that was kind of my demonstration, was showing that this actually can be incorporated into your office workflow, and it does not have to, since you can check real-time eligibility for insurance cases real-time through the computer without having to sit on the phone with the insurance company. These are ways to make that much more efficient for you and not to add to the time and effort on the part of the practice. Let's see, the next question is, if you do not have a negotiated rate with an insurance company, how are you able to give an out-of-network estimate if the insurance company does not give you the rate, the pay out-of-network prior to the procedure? So the example I'll give is that your out-of-network rate is whatever you decide you want it to be. The issue is whether the patient has out-of-network benefits. If you charge $10,000, that's just your made-up out-of-network rate, and because you don't have a contract with the insurance company. It's more if the patient has a contract with the insurance company, whether they have out-of-network benefits with that insurance company. If they don't, then they'll be on the hook for the whole fee. If they do have out-of-network benefits, then they'll have to do their same cost sharing of whatever your fee is. Is that make sense to you, Joe?
Yeah, that's right. I mean, yeah, if there's something that insurance company doesn't cover, the process has not changed. If it's something that they do cover and you're out of network, well, then, there's a variety of things we talked about over the last hour that could potentially apply.
All right, so this is a similar question about a patient coming into the ER, but the issue now is that they're a Medicaid patient. So No Surprises Act doesn't really apply to that Medicaid patient, and it would go back to the same, you wouldn't necessarily have to get consent, so you just have to talk to the patient about paying cash, I guess, because they're not really in network or out of network either.
Yeah. I mean, it would be a question. I mean, that's an interesting question. I mean, I guess when they're asking to do something that's not technically covered by Medicaid, for those purposes, they're not technically a Medicaid patient, they're a self-pay patient, so some of the good faith estimates may apply. But it's a narrow case. I recognize that that's how the world works, is around narrow cases, but that would be the situation. Otherwise, it would be sticking to the Medicaid coverage and all the Medicaid rules up until you get to that point where the patient's asking for something that's outside the scope of Medicaid entirely, in which case then you'd flip over to some of the good faith estimate for self-pay requirements.
All right. And then this next question is, you've talked a lot about out of network, but what about in network? Do we provide a good faith estimate for all those in network cases? Because
yes,
a lot of these,
eventually, as of they need to be regulated, right? So there's no requirement. There's technically the law makes it required as of January 1st, 2022, but the agency's been very clear that there's not any expectation that they're going to be doing anything like that they're going to be enforcing this until they've regulated around it. They said that in the previous rules. And so the answer is yes, just not yet. And that's what Dr. Kaplan asked before about when those rules might come out. I think mid this year, you could start to see some idea of how they're thinking about all this, but we're not quite there yet.
Yeah, so in-network is on its way, and in the big picture, there's going to be an expectation that healthcare patients are going to be getting estimates for everything beforehand, unless it's an emergency, of course. But that's where this is moving towards. So just to confirm, if we perform an emergency surgery in the hospital, the insurance company will pay an amount based on their geocode. But is there any arbitration or negotiation that can be done if the payment is low? Yeah, that's just going back to, yeah, if it's an emergency, you absolutely can't charge an out-of-network rate. Right now, that's going to be the median in-network rate based on the qualifying paying amount, based on the area you're in. As Joe was describing, you can go through a dispute resolution process, but as of right now, that's tied to the in-network, the median in-network rate, unless the lawsuits provide some other guidance. Okay, next, there's another. Do they have to sign to acknowledge they received the information on the No Surprise Billing Act, or can it simply be posted at the front desk with no signature required? No, they have to sign the quote that you give them, as I demonstrated how that's already incorporated into the quote. All right, and then the other one is, how do we get the software? You can just email me at this the email address that's on the screen. Oh no, here's another. Oh yeah, no, somebody was thanking us that this was very informative, and that's a really great place to stop. We're exactly at 1 o'clock Pacific time. So Joe, again, I really want to thank you so much for your insight. Really appreciate it. Those are questions that I could not have necessarily answered on my own, and just having the background you have with CMS and everything, it was just very it was very helpful. I appreciate your time.
Yeah,
thanks for joining us. And
you.
you're sure you're okay if people email you, right?
Yeah, that's fine. There are times I'm going to say that's operational. You can use the other email address because I don't want to mislead anyone, but from a regulatory perspective, always happy to help.
Exactly right. All right, thanks again, everybody, and you will receive an email with a link to this video in your inbox in the next couple of hours. Thanks again. Y'all have a great day.